Welcome back, everyone, to the deep dive. Ready to tackle another complex topic in endocrinology.
Always ready for a challenge.
Today, we're going deep on menopausal hormone therapy, or HT. I know, we're all endocrinologists here.
We know HT.
Right, we know the basics, but
That-
there have been some pretty significant shifts in the landscape, especially since those Women's Health Initiative trials, the WHI trials.
Absolutely. Really changed how a lot of us approach HT.
For sure. And that's exactly why we're doing this deep dive, to revisit those findings, but with a fresh lens, you know?
With all the new research and data that's come out since then.
Exactly. We're talking about specific formulations, the different routes of administration, and most importantly, how all of that impacts your decisions in the clinic.
Especially those tricky cases where the textbook answer just doesn't cut it.
Exactly. So let's rewind the clock for a minute and think back to those WHI trials. Remember all those concerns about breast cancer and cardiovascular disease risk?
Oh yeah, it led to a huge decline in HT prescriptions almost overnight.
It did. It really did. But here's where things get interesting. The data that's emerged since then has really highlighted the importance of one crucial factor.
Timing.
Exactly, age and timing.
The timing hypothesis, it's been a real game changer.
It has. So for healthy women under 60 or within 10 years of menopause, the benefits of HT often outweigh the risks, especially when we're talking about those pesky vasomotor symptoms that women experience, like,
The hot flashes.
yeah, the hot flashes, night sweats, things like that.
Right.
And more recent studies like KEEPS and ELITE have really reinforced that. They've shown a much more favorable safety profile when HT is started earlier. It's not a one-size-fits-all approach anymore, that's for sure.
No, it's not. But with so many HT options available now, choosing the right one for a particular patient can feel a little overwhelming.
Oh, tell me about it. You've got estrogen therapy, estrogen progestogen therapy, TSEC, low-dose vaginal estrogen.
And then you've got all the different ways to administer it: oral, transdermal, topical, vaginal.
It's a lot to consider. So where do you even begin to sort through all of that?
Well, I think the key is understanding the nuances of each option. Like with oral estrogens, for example, they're the most widely prescribed. But that first pass metabolism through the liver can lead to some potential issues.
Like what kind of issues?
Well, there are concerns about venous thromboembolism, hypertriglyceridemia, maybe even gallstones.
Right. So maybe just popping a pill isn't always the best route.
It depends. What about those transdermal and topical options? Those seem to be gaining popularity these days.
They are. So what's the benefit there?
Well, by bypassing the liver, you can often get away with a lower dose, and the metabolic impact is usually much less pronounced.
Interesting. So fewer of those side effects we were just talking about.
Exactly.
Makes sense. Now, what about those localized vaginal estrogens? Those seem pretty straightforward.
They are. They work really well for those localized genitourinary symptoms of menopause:
You mean like?
vaginal dryness, painful intercourse.
Right.
You get relief without the systemic risks because they're acting mainly locally.
Okay, I got it. Now, before we get too deep into the weeds with specific formulations, I think we need to talk about the big elephant in the room, the risks associated with HT.
The risks?
Yeah. It's what I think makes some patients, and maybe even some doctors, hesitant to prescribe or use it.
Understandable.
Especially after those WHI trials.
Exactly. So let's break down some of those key concerns, starting with cardiovascular disease.
Right. Well, first of all, it's important to remember that the idea that hormone therapy automatically increases cardiovascular disease risk is a bit of a misconception.
Really?
Yeah. The research actually shows that the risk is mostly elevated for women who start HT later in life, like over 60 or more than 10 years past menopause.
So that timing hypothesis comes into play again.
Exactly. When we initiate HT earlier, we're more likely to see those cardiovascular benefits. And of course, we always need to consider a woman's individual cardiovascular risk factors. We can't just treat everyone the same. Of course, of course. Now, what about stroke risk? I remember that being another concern that came out of the WHI trials.
It was, and the evidence on that is a little less clear. Some studies show an increased risk, some don't. But the general consensus seems to be that, like with cardiovascular disease, the risk is age dependent.
So if you start HT under 60 or within 10 years of menopause.
The data suggests no increased risk.
Okay, so age and timing, big factors here too. Anything else we should be aware of?
Venous thromboembolism, VTE,
Ah, right.
We know that oral estrogens can increase that risk, but transdermal options appear to be safe, and choosing the right progestogen can also help.
Okay, good to know. But what about breast cancer? I think that's the one that's on everyone's mind.
It is, and it's a complex issue. But the most important thing to remember is that breast cancer risk associated with HT isn't a one-size-fits-all thing. It really depends on the type of therapy.
So it can't just say HT increases breast cancer risk.
No, not necessarily. For example, combining oral conjugated equine estrogens, OCEE, with medroxyprogesterone acetate, or MPA, has been shown to increase the risk. But studies have actually shown that OCEE alone might actually reduce both breast cancer incidence and mortality.
Wow, that's a pretty significant difference.
It is.
So how do we make sense of that in practice? When would we consider estrogen-only therapy?
That's where individualized care comes in. You have to look at each patient's risk factors, family history, personal preferences, and of course, have those open and honest conversations about the potential benefits and risks.
Shared decision-making.
Obviously.
All right, so we've talked about the classic menopausal symptoms, hot flashes, night sweats. But HT can also be a powerful tool for other issues too, right?
Oh, absolutely. We can use it for a whole range of things, like osteoporosis prevention, for example.
Right. Osteoporosis, that's a big one, especially as women age. What does the research say about that?
Well, we know that HT can reduce the risk of hip and vertebral fractures, and it's actually comparable to bisphosphonate therapy in terms of effectiveness.
Really?
Yeah, but there's a catch. The benefits seem to diminish after treatment is stopped.
Oh, so it's not a permanent solution.
Not always. We may need to consider other therapies down the road.
Okay, so it's something to keep in mind. What about other conditions? I've heard some buzz about HT and type 2 diabetes.
There's definitely a connection there. Studies show HT can improve blood glucose control, boost insulin sensitivity, and even reduce the risk of developing type 2 diabetes.
Oh, that's pretty remarkable. But for patients who already have insulin resistance, are there any special considerations?
Absolutely. You really have to monitor their blood glucose levels very carefully, especially when you're first starting them on HT. You want to be able to catch any fluctuations early.
Good point. So bone health, diabetes, what about metabolic syndrome? That's another one that becomes more common after menopause.
It is. And HT can actually play a role there too. It can help shift fat distribution away from the abdomen and potentially improve lipid profiles.
So it can have a positive impact on body composition.
Exactly. Although the effects do seem to vary depending on the HT formulation and how it's given.
Makes sense. So choosing wisely is key. Any other areas where HT might be beneficial?
Well, dementia often comes up. I know the WHI data raised some concerns, but the timing hypothesis seems to apply here as well.
Of course it does.
Right. Newer studies like KEEPS and ELITE suggest that starting HT earlier in menopause actually has neutral effects on cognitive function.
That's great news. So for women going through early menopause, before 45 even, HT could be really advantageous in the long run.
Potentially, it could help protect against some of the health risks that come with early estrogen deficiency. But of course, we always need more research.
Okay, fair enough. But we also have to be realistic. There are situations where HT just isn't appropriate, right?
Definitely. Women with a history of breast cancer, for instance, we usually advise them to avoid systemic HT because of the potential increased risk.
Right, because of the risk of recurrence.
Right. But there are other options. Non-hormonal therapies can be really effective for managing hot flashes. Certain antidepressants or gabapentinoids, for example.
So there are other ways to help them. What about women who are past 60 and still having symptoms? Do they just have to live with it?
Not at all. A lot of women continue to experience vasomotor symptoms well into their 60s and beyond, and extending HT use beyond 60 can be an option, but we have to weigh the risks and benefits very carefully in that age group.
So it really comes down to personalized care.
Exactly. It's about open communication, shared decision-making, and staying current on the research. That's how we ensure the best possible care for our patients.
I couldn't agree more. It's really about moving away from those general recommendations and recognizing that every woman is different.
Absolutely. We can't just treat everyone the same. It's about looking at the individual patient and understanding her needs and her risk factors.
Exactly. Sounds like a lot for us to keep in mind as endocrinologists. Any final pearls of wisdom you want to leave our listeners with?
I think the key takeaway here is that the landscape of menopausal hormone therapy is constantly changing.
It is always something new to learn.
Right. And that means our critical practice has to adapt too. We have to stay up to date on the research, and we have to be willing to question our assumptions.
Be open to new evidence.
Exactly. And when it comes to HT, shared decision making is crucial.
Couldn't agree more.
It's about having those open and honest conversations with our patients, explaining the complexities,
Mm.
and working together to find the best path forward.
It's about empowering them to make informed decisions. So before we wrap up, what's next for HT research? What are those big unanswered questions that are still out there?
Oh, there are so many, but I'd say one of the most pressing is the long-term impact of different HT formulations on cognitive function.
Hmm.
What's the real story with dementia risk?
Yeah, that's a big one.
And personalized medicine is really the future.
It is.
Figuring out how individual genetic and lifestyle factors influence a woman's response to HT.
That would be incredible.
It would revolutionize how we approach treatment.
It really would. It sounds like the future of HT is going to be pretty exciting. So what's one thing you think every endocrinologist should be thinking about when it comes to hormone therapy?
I think the most important thing is remembering that HT is not one size fits all.
Right, right. We've said that a few times now.
But it's really important. We have to take an individualized approach, consider all the factors we've discussed, and find the right treatment for each patient.
No more cookie cutter solutions.
Exactly.
And I have no doubt that with continued research and that commitment to personalized care, you can help your patients navigate menopause with confidence.
That's the goal.
Thanks so much for taking the time to walk us through all of this.
It's been a pleasure.
To all our listeners out there, thanks for joining us for this deep dive into the world of menopausal hormone therapy. Until next time, it really highlights the need for us as endocrinologists to stay on top of the research.
Absolutely. We can't just rely on what we learned in residency or fellowship.
Exactly. There's always something new coming out. So as we wrap up this deep dive, what's one key takeaway you want our fellow endocrinologists to remember? What should they be thinking about when they go back to their clinics?
I'd say the most important thing is that menopausal hormone therapy is not a static field.
It's constantly evolving.
Exactly. It's dynamic, it's nuanced, and it really demands that we stay curious and stay informed. But most importantly,
We need to individualize our approach to treatment.
absolutely.
It's about recognizing that each woman is different. Her own story, her own risk factors, her own goals for treatment.
It's about empowering women to make informed decisions about their health during this time of life.
And it's about us being equipped with the most up-to-date knowledge to guide them. So before we sign off, what are you most excited about when it comes to the future of HT research? What are you hoping to see?
Oh, there's so much. But I think personalized medicine is really the future of HT.
Personalized medicine, what do you mean by that?
Well, imagine if we could use a woman's genetic profile or her lifestyle to predict how she'll respond to different HT formulations.
So no more trial and error.
Exactly. We could tailor treatment to her individual needs from the very beginning.
That would be a game changer.
It would revolutionize how we approach HT. And that's the kind of future I'm really excited to be a part of. A future where we can help women navigate menopause with more confidence and better outcomes.
It's a powerful vision, and I have no doubt that with brilliant minds like yours working on it, we'll get there. Thanks again for joining us today. It's been a fantastic conversation.
My pleasure.
And to all our fellow endocrinologists out there, keep those questions coming, keep pushing the boundaries, and keep advocating for your patients.
We're all in this together.
Until next time.